We have only one item on the agenda today. It's House Floor Amendment Number 2 to Senate Bill 1950. The plan today is to present the bill. The sponsor will present the bill, and then we'll hear from witnesses on each side. We've selected, or the sides have self-selected 4 people to speak affirmatively as proponents and 4 to speak as opponents. We'll also have people available on each of the sides to answer questions if need be. I'm asking because we want to make sure we allocate enough time for members to have discussion and questions on such an important topic. I'm asking the witnesses to please limit their testimony to 3 minutes. I have this 3 here. I'll be timing. And obviously, it's a very important topic, and I don't want to rush anyone, but I want to make sure and allow members the time to ask the questions and get the questions answered and make their comments, et cetera. So with that in mind, when you're ready, Leader Gabel. Oh, and can we please, Madam Clerk, add Representative Hernandez to the roll? Go ahead.
Thank you. Thank you, Madam Chairwoman. I am pleased to be here again. We had a hearing on this just recently, a subject matter only, and today we are here to vote on the bill. So Senate Bill 1950, the end-of-life options for terminally ill patients, or called Deb's Law, would authorize medical aid in dying in Illinois. Medical aid in dying is a trusted and time-tested medical practice that is part of the full spectrum of end-of-life care options, including hospice and palliative care. Deb's Law would allow terminally ill, mentally capable adults with the prognosis of 6 months or less to live to request from their doctor a prescription for medication that they can decide to self-ingest to die peacefully in their sleep. Medical aid in dying is authorized in 12 jurisdictions now: Oregon, Washington, Montana, Maine, New Jersey, Vermont, New Mexico, Colorado, California, Hawaii, Washington, D.C., and now includes Delaware after the signing of their May legislation on May 20th. Beyond authorizing medical aid in dying for a terminally ill adult who is an Illinois resident and has a 6-month prognosis, as confirmed by 2 Illinois physicians, Deb's Law also requires the following steps. Qualified individuals must be able to self-administer, i.e. self-ingest, the medication. Physicians must inform the requesting individual about all of their end-of-life care options, including comfort care, hospice, palliative care, and pain control. No physician, healthcare provider, or pharmacist is required to participate in the law. The individual can withdraw their request for medication or change their mind after receiving the medication and decide not to take it, and 38% do that. An individual's providers may refer the person for a mental health evaluation to ensure the person's capacity to make an informed decision. The law includes multiple protections to prevent coercion, including strict eligibility requirements, 2 separate physician assessments, and mandatory counseling on all treatment options. The law makes it a felony to coerce someone to request the medication or to forge a request. Life insurance payments cannot be denied to the families of those who use the law. Healthcare providers who participate and comply with all aspects of the law are given civil and criminal immunity. Healthcare providers must submit documentation of medical aid in dying deaths to the state health department so it can compile an annual report for lawmakers and the public, and death certificates list the terminal illness, terminal disease as the cause of death, consistent with statutory language to provide accurate data and to prevent inappropriate suicide investigations. The law includes several other regulatory requirements: 2 verbal requests for the medication directly from the patient with a 5-day waiting period between the first and second request. A written request is also required from the individual requesting medical aid in dying. Prescribing physicians must comply with medical record documentation requirements, and unused medication must be disposed of according to state and federal law. There was polling done, which I'd like to share with you. In a February 2023 poll of 700 likely Illinois voters conducted by Impact Research, more than 7 out of 10 Illinois voters, 71%, including 73% of voters living a disability, agreed with, they think, a mentally capable adult patient with an incurable terminal illness who only has 6 months or less to live should have the legal option of medical aid in dying to pass peacefully in their sleep. Less than 1 out of 5 voters, 17%, oppose this legal option of medical aid in dying. Majority support for medical aid in dying spans the age, gender, racial, and religious spectrum. White voters, 69%. Black, African American voters, 69%. Hispanic Latino voters, 86%. Catholics, 69%. Non-Catholic Christians, 58%. And atheist, agnostic, non-affiliated, 89%. In a February 2021 Medscape WebMD poll, nearly 6 out of 10 Illinois physicians, 58%, said they support medical aid in dying, also called physician-assisted death, a practice in which a terminally ill adult with decision-making capacity asks for and receives a prescription medication that may be self-ingested to hasten a foreseeable death. Only 1 out of 10 Illinois physicians oppose medical aid in dying. When physicians were asked whether they support or oppose potential medical aid in dying legislation and were informed about 8 stipulations in a potential law, support increased from 58% to 65%, and opposition decreased from 25% to 20%. There are also many safeguards in this legislation. So Deb's law, like all medical aid in dying laws in the U.S., contains core safeguards to protect patients from abuse and coercion under the law. Patients, not doctors, nurses, or healthcare proxies, must initiate a request for medical aid in dying. The patient must make 2 oral and 1 written requests for medication. The written request must be signed by 2 witnesses, one of whom cannot be related to the person, nor can they have a stake in the person's estate. The patient must have a terminal diagnosis with a 6-month prognosis and must be capable of making medical decisions for themselves. The patient's diagnosis, prognosis, and decision-making capacity are evaluated by 2 physicians. If there is any doubt at all as to the patient's mental state or decision-making capacity, they must be referred for an evaluation by a mental health specialist. No person qualifies for medical aid in dying solely because of disability or age. The patient must ingest the medication themselves via the GI tract by swallowing, feeding tube, or rectal catheter. The medication may not be injected into a vein or administered by IV. It may not be administered to the patient by a third party. There are criminal penalties for any person who coerces or induces a patient into accessing MAID. In the 28 years since Oregon's law went into effect, there has never been a single verified case of abuse or coercion under the law. Nobody has ever been charged criminally for violating the law. No medical professional has ever faced disciplinary action. Medical aid in dying is a time-tested, the safeguards work. Opponents of MAID will sometimes cite cases from Canada, Europe, or other countries to justify their criticism. We are not Canada, made laws in the U.S. operate within a distinct legal environment and differ sharply from other countries in how patients qualify for and request the medication. It is impossible to compare what is happening in Canada with the bill in Illinois. Questions occasionally come up about the pharmacology of this bill. The medications most commonly used across the country for MAID patients is a compounded mixture called DDMA-PH, containing Valium, digoxin, morphine, amitriptyline, and phenobarbital. The medication typically causes patients to fall asleep within 2 minutes to 2 hours, and death occurs within 30 minutes to 8 hours. Made in practice. Across the authorized jurisdictions that report data, 10,211 individuals to date have chosen to use medical aid in dying. This is less than 1% of the people who die in each jurisdiction use this law. Only 62%, just under 2/3 of people with prescriptions, ingest the medication and die. Up to 38% of the people who go through the process and obtain the prescription may never take it. This group consists of people who die without using the medication, whether from illness, another cause of death, or an unreported reason. In any case, we hear from terminally ill people that they derive peace of mind simply from knowing they have the option if their suffering becomes too great. The majority of terminally ill people who utilize medical aid in dying, 88%, are enrolled in hospice or palliative care services at the time of their deaths, according to annual reports for which hospice and palliative care data is available. Thank you.
Thank you for that. And so procedurally, we'll go ahead and have the proponents for witnesses testify. Then we'll move to the opponents for witnesses, and then we'll go to questions. With that, I think we have first up a virtual witness. One moment. Deb Robertson, welcome, and please go ahead when you're ready. And I'd ask, I apologize, but if you could keep it on the short side to 3 minutes, that would be great. Thank you and welcome.
House Executive Committee, good morning. My name is Deb Robertson, and I wanted to thank you for allowing me to share my story and explain the critical need for SB 1950, a measure that will provide terminal ill adult Illinoisans, like myself, a full range of end-of-life options, including medical aid in dying. I was diagnosed in January of 2022 with an aggressive terminal cancer called neuroendocrine carcinoma. After a series of follow-up tests, I was told there was no cure for my disease. I am going to die. I've continued to fight since my diagnosis. After trying 4 types of chemotherapy, they all stopped working. More recently, I've been in a clinical trial. It showed some progress. But last month, I found out my cancer has spread to my brain. I've watched so many people who share my diagnosis struggle in pain to the end of their lives, struggling till their very last breath. Today, the end for me is near. And I say that not for your sympathy, but so you can understand why I want to spend part of the last time I have working on behalf of terminally ill Illinoisans and their families to have access to a full range of end-of-life options, including medical aid in dying. Let me be very clear. I love life. I don't want to die. I love my wife. I love my children, my grandchildren, extended family, and friends. But I'm going to die. And when the time comes, I pray that this committee and your colleagues will allow me and other terminally ill Illinoisans utilize this option at the end of life. This legislation is about options. I was not given the option about my disease, but I deserve the option about how and when I leave the earth. I want to enjoy the time that I have left with my family and friends. I don't want to worry about how my death will occur. It's really the last bit of control left to me. But I can only have those options with your permission. And that, again, is why I'm spending a portion of my time remaining to ask this committee to support the option of medical aid in dying in Illinois. I want the option to die peacefully and on my own terms, here in Illinois, surrounded by my family and friends. As someone who's come to grips with their own mortality, I know there's comfort in having the option of medical aid in dying, even if I never decide to use it. Let me speak for a moment to those in the room who do not want terminally ill people from Illinois to have a full range of end-of-life options. I respect your passion. All I ask is that you respect my desire to have this choice. Medical aid in dying does not change the fact that I'm going to die soon. It only gives me some choice about the end of my life. House committee members, I urge you to show your empathy for Illinoisans like me and support medical aid in dying in our state, so many folks like me and our families will be eternally grateful. Thank you for allowing me the opportunity to speak to you today. Please vote yes. Thank you.
Thank you, Ms. Robertson, for sharing your story, and we wish you only the best.
Thank you.
Before I move to the next witness, I would like to see if the spokesperson will waive the reading of the slips. I do note we have filed online. We have 525 proponents filed, 2,176 opponents filed, and 26 people taking no position. We will waive those reading and move on to the next witness. We have an in-person witness who's approached the table. Beth Langen, please go ahead when you're ready.
Thank you. Good morning, Chairperson Williams, Spokesperson Spain, and members of the Executive Committee. My name is Beth Langen. I'm here to testify in support of Senate Bill 1950, House Amendment 2, Deb's Law. I became disabled due to a traumatic injury when I was 17. And the first thing I felt was a tremendous loss of control over my life. And much of what I've done since, much of what I've worked for, is to regain and to retain that, medically, economically, personally. It's why I embrace the most fundamental principle of the independent living movement and the disability rights and justice movement, that all of us, regardless of circumstance, have and deserve the right to self-determination, to make decisions about and to exert control over our own lives, including what care and services we receive. That was 50 years ago. And as I've gotten older, the odds have gotten increasingly better that I will die as a result of a terminal condition that any of us may face, like heart disease or cancer. We as a culture don't deal particularly well with the only thing in life that's certain, and that's our eventual death. And I think the most frightening thing about it is the loss of control. I want for myself, for those I love, for anyone else, the right to have some modicum of control, not just about how I've chosen to live, but how we approach our death, if it is from terminal illness. And this is about terminal illness, not acute or chronic illness or conditions that can be managed with treatment. So death elicits fear. And I understand how all of the discussions about it can elicit fear. And for those of us who've experienced disability, age, poverty, race, other socially imposed constructs, we sometimes fear being devalued and dismissed by systems, including medical systems, when we face chronic or acute care situations. And that's not what this bill is about. It's about terminal situations, and disability is not terminal. Death, like life, is easier to navigate when you know you have options to choose from, even if you never need to, even if you choose not to. The ability to control the decision-making process in this bill is detailed and it's robust. It's really a very high bar to be eligible to participate. It requires you to be fully in control of the decision-making process and the administration of medication, only when you have a prognosis of less than 6 months to live. It requires consultation with multiple different medical professionals, and the provisions are really strong that prevent anyone from assisting or exerting undue influence, including the person who you may have already given healthcare power of attorney. It is a trusted and a transparent medical practice that's part of a full spectrum of life and end-of-life care options, including hospice and palliative care. People literally move across the country to access it. For those with disabilities, or who are marginalized by poverty, or for whose terminal illness prevents it, I think it's a matter of equity that they have the option to choose it where we live. This bill does not lessen anyone's control. It doesn't rob me of choice over our lives or at the point where our lives reach the inevitable, unavoidable end when no treatment can improve or reverse it. As somebody who's learned to never take for granted my right to self-determination, I hope that Illinois will join the many other states who extend this ability to end our lives so that all of us can choose a death that is peaceful, one that is without unnecessary suffering, and one with less fear. You don't make public policy based on fear. And fear doesn't make for really good healthcare decisions. It's not how we live. It's not how anyone wants to die. So I really hope you'll support this bill for anybody who is able to and who wants to have another choice as they face terminal illness. Thank you so much.
Thank you for your testimony today. Next up, Susie Flack. Welcome back to the committee, and thank you for being here in person.
Thank you. Hello, my name is Susie Flack. I am a lifelong resident of Illinois and recently retired from a career as a special education teacher. I'm here today to share the story of my son, Andrew, who utilized his right to medical aid in dying while living in California. In 2017, Andrew had moved to California and was living his dream, pursuing his special education career and finishing up his master's. He sought medical attention because he started to feel fatigued, and within days he was diagnosed with stage 4 colorectal cancer. When Andrew called to tell me of his diagnosis, I pleaded with him to return to Illinois to be surrounded with his family and friends where we could easily support him. Andrew was very optimistic and said that he preferred to stay in California, assuming his treatment would include chemotherapy, radiation, and some surgery, similar to a treatment he received when he was diagnosed at 4 years old with kidney cancer. But this is where the similarities end. Andrew's cancer was very aggressive. This adult cancer ravaged his body. He underwent several forms of chemotherapy, several bouts of radiation, and continued to pursue medical trial options. Our family is very fortunate. We have the financial means to go back and forth and support Andrew from afar. However, it was very difficult. In fact, it was in 2019 when Andrew was in the hospital for a routine infection that he heard the words, "Your cancer is terminal." My baby was alone when he heard those words, something that will always haunt me. His team of doctors continued to support him, and he underwent medical trials, immunotherapy, palliative care, eventually hospice, and a lot of morphine. The cancer continued to progress, and eventually his quality of life consisted of laying precariously on the couch to avoid the open wounds that were covered his body. You might hear the opposition refer to this as assisted suicide, a term I find very misleading. For you see, Andrew woke up every day with one intent in mind, and that was to make it to tomorrow. He drew lines in the sand of when he would take the medication, and those horrific things happened. But rather than take his medication, he continued to move those lines until eventually, in November of 2022, Andrew woke up and the pain was unbearable. He said, "I'm ready." We had a day filled with Mario Kart adventures, board games, and sharing favorite childhood memories. At sunset, we followed Andrew into his bedroom. His sisters, my ex-husband, myself, his two roommates, and Jackson the dog kneeled around the bed as Andrew lay. He was a lover of music and made a special going out tape, which included the Beatles, Tom Petty, and other classics. As we listened to those songs, we shared our favorite memories of Andrew. Finally, the hospice nurses came in. They gave him his medication mixed with raspberry sorbet. Having not eaten for days, he licked that spoon. Within 2 minutes, Andrew fell asleep. 2 hours later, he peacefully took his last breath. His final words that evening were, "I'm happy." Andrew was 34 years old. I urge you to support this tried and trusted bill and become a leader in the Midwest so that other Illinoisans do not suffer the same fate as my son. Thank you for your time.
Thank you for sharing your story with us again. Our final witness for the proponents is Dr. Diana Barnard, who is on Zoom.
Thank you. My name is Dr. Diana Barnard, and I am board certified in family medicine as well as hospice and palliative medicine. I have more than 30 years of clinical experience and have spent the last half of my career focused exclusively on caring for patients and families navigating serious and terminal illness. In 2025, the way we die looks very different than it did many years ago, when most of us died suddenly or after very short-lived illnesses that we had few tools to treat. Modern medicine has made it possible for many of us to live much longer lives and to live with more disease in the more advanced stages of disease. This progress is really to be celebrated. But this same progress means that more of us are living that final phase of life with a very heavy disease burden. More disease burden can mean more symptoms, and more symptoms sometimes means more suffering. We need new tools to address this suffering, which can be prolonged and complex. I have cared for thousands of terminally ill people and watched hundreds of people die. And each death is so private and deeply personal. Some will find deep meaning in the dying process with symptoms that are reasonably well managed. But others experience suffering that is difficult or impossible to alleviate, even with the very best of palliative and hospice care. Suffering which feels meaningless and needless when it comes at the very end of life. As you have heard, people living with terminal illness want very much to live. It is only when their treatment options become exhausted or have intolerable side effects, then those same dying patients want a little bit of a say in how they die. Each individual has very specific thoughts about how they want to live their final days and what constitutes an unacceptable quality of life for them. Medical aid in dying is about respecting the broad diversity of individual needs and values at a profoundly, profoundly private time. It is completely voluntary for patients as well as physicians, and those who do not believe in the concept have no obligation to participate. You will hear from people who are fearful about medical aid in dying. These fears are exaggerated and unfounded. As you have heard, the laws have strict eligibility criteria and several safeguards. I speak for 28 years of experience with the practice across the country. The laws are working well, and they are working as intended, without abuse and coercion. In Vermont, medical aid in dying has been legal for 12 years. Our most recent report showed that 203 people qualified for the practice. Cancer was the most common diagnosis. All Vermonters have benefited from having the option of medical aid in dying in the setting of terminal, unremitting suffering. Again, as you have heard, death is inevitable. Suffering need not be. Please see my written testimony for additional thoughts.
Thank you, Dr. Barnard, for being here with us today. We will next go to the witnesses for the opponents, and we have four. Julia Morel will be first.
Thank you for your support.
And I believe she is via Zoom. Go ahead and get started when you're ready.
Right. Members of the committee, my name is Julia Morel, and I'm speaking in opposition of Amendment 2 of SB 1950, which seeks to legalize assisted suicide. I'm grateful that when my dad, Paul Morel, received a stage 4 cancer diagnosis, he was living in Massachusetts, where representatives like you had passed legislation that supported my dad's fight to live. Because of exceptional efforts and extraordinary medical treatment, my dad lived for 6 more years, far beyond any prognosis ever given to him by skilled and caring doctors at Dana-Farber in Boston. And I even got another little brother, even though the doctor said that that too is not possible. Had assisted suicide been legal in Massachusetts, my dad could have been denied coverage for the very treatment that elongated and enriched his life. He could have been eligible for suicide on the basis of a prognosis that was inaccurate by a factor of years. In Oregon, where assisted suicide has been legal long enough for its true colors to metastasize, the list of conditions which are eligible for a lethal prescription has grown to include diabetes, heart disease, and arthritis. We have the ability to treat these people, but the pressure for cost containment in a profit-driven healthcare system creates a future where it is possible that your constituents could be denied proper treatment that would prevent their death. And this is not speculation. Let me read directly from the law. The rate charged for any policy shall not be conditioned upon or affected by the making of a request by a person for medication to end his or her life. Now, I could be reading from Oregon's Death with Dignity Act, or I could be reading from Amendment 2 of SB 1950, because the language is the exact same. This amendment did not change a thing, except to add that, quote, failure to meet this requirement shall constitute a violation of the Illinois Insurance Code, a violation which simply carries a fine of up to $250,000, or, in other words, not even 4 election cycles worth of pharmaceutical and health insurance donation lobbies to Representative Gabel. And this is chump change for an insurance company, but not for your constituents. Its value is their life. And it's not chump change for a 64-year-old cancer patient in Oregon who's denied coverage for a $4,000 a month life-saving treatment, where instead her insurance company offered to pay for her suicide for the cheap price of $50. And this was 13 years after the so-called safeguards that I just read were codified. And speaking of safeguards, do you know what percentage of patients were referred for the safeguard psychiatric evaluation that was recommended by Oregon law, just as this amendment recommends, before receiving the lethal prescription? 1%. 1%! This is not medical aid or compassionate care. With your vote for the selective legalization of suicide for a certain class of people, the House of Representatives for the people of Illinois makes its judgment clear that the sick in their time of greatest need do not have lives worth living or worth paying for. But every unpredictable day of my dad's life mattered. I learned by watching his strength and accepting weakness, and as a daughter, I was able to serve my dad as he had served me. And believe me, from the depths of my heart, I empathized with the multi-layered suffering of end-stage terminal illness. Yes, I witnessed my father's gradual confinement to his bed, but I also saw the immeasurable relief brought by palliative care and hospice, services that shepherd the dying through the process in a truly compassionate way. Proponents of this bill want to portray natural death as necessarily painful, undignified, costly, and humiliating. They want to tell you that this bill will increase patient choice. But the reality is that the inevitable consequence of the legalization of assisted suicide is the release of a money-hungry wolf in the sheepskin of patient choice. It is a truly dangerous, slippery slope of denied treatment for those who have the right to fight to live. Thank you.
Thank you for your testimony. I will note that we will not tolerate personal attacks as part of this testimony. I understand that everyone feels very strongly about this topic, but please keep that in mind moving forward. That will not be tolerated. Next up, we have Dr. Solmasi, also via Zoom.
Thank you very much. I'm Daniel Solmasi, a professor emeritus of medicine and a former associate director of the McLean Center for Clinical Medical Ethics at the University of Chicago. I'm now at the Kennedy Institute of Ethics in DC, and I strongly oppose Amendment 2 to SB 1950. Today I want to just highlight some of the many reasons I think we all ought to be opposed. The first is that it subverts medical ethics. And the second is that all your proposed safeguards are eventually going to be seen as barriers and eliminated. The patient-physician relationship really requires a space of profound trust. And the very possibility that a doctor will help patients to kill themselves actually fundamentally undermines that trust. We don't heal by killing. We can treat symptoms better than has ever been possible in the history of medicine, and suicide should not be necessary. And despite what you've heard, data show that the main reasons that people who use such laws are not pain, but loss of autonomy, dependence, and feeling like a burden. This means that the state and medicine are sanctioning the idea that such lives are unworthy of being lived. Not only does this disrespect disabled persons who live lives that are dependent upon others, it makes them understandably nervous about the possibility of third-party determinations that their lives are unworthy of being lived simply because they're dependent. The three largest medical organizations in the world oppose assisted suicide: the World Medical Association, the American Medical Association, and the American College of Physicians. Moreover, all of your proposed safeguards are either naive or perhaps you've been deceived. First, the data show that physicians are not very good at prognostication. You just heard that. Patients given 6-month prognoses often live for years. And while 40% of dying patients may show signs of depression, the data from Oregon, as you heard, show that only 1% of patients requesting lethal prescriptions are ever seen by a psychiatrist. And once these bills are passed, all the safeguards that are in them come to be seen as barriers. And this is already happening in other states that have passed these laws where residency requirements are being dropped, as in Oregon and Vermont. Waiting periods are being shortened, as in California, Colorado, and New Mexico. Nurses are being empowered to prescribe, as in Hawaii and Delaware. Conditions like diabetes can be considered terminal, as has happened in Oregon. Hypertension and high cholesterol have been listed as qualifying conditions in Maine. Paralyzed persons who can't self-administer the drugs are being spoon-fed lethal medications, as has happened in Oregon and California. And psychiatric conditions like anorexia nervosa are being called terminal, as has happened in Colorado. For the future, I think you will reach a tipping point when enough states pass the laws that we will begin to look like Canada, Belgium, and the Netherlands, where 5% of all deaths, practically the leading cause of death, is being euthanized. And people feel pressure to ask to be euthanized. This law subverts medical ethics, and I think you will be deluded if you think it's going to be limited in the way the bill suggests. If you want to really help dying people in Illinois, Put your effort into improving hospice, making more people eligible, expanding the benefits, rather than helping dying persons kill themselves. Thank you.
Thank you for your testimony. Next up, we will go to our in-person witnesses for the opposition. I believe Dr. Salvador, when you're ready, welcome back.
Hello, my name is Dr. Nushiglu Salvador, and I'm a board-certified physician in internal medicine, palliative care and hospice medicine, and integrative medicine. And I'm a fellow of the American College of Physicians, which is a professional medical society that opposes assisted suicide. I have been a licensed practicing physician in the state of Illinois in both inpatient and outpatient settings for over 25 years. I am here to express my grave concern with the SB 1950 bill, which is the physician-assisted suicide bill. Although many cite uncontrolled pain as a compelling reason for passing an assisted suicide bill, data from Oregon indicate that pain and anticipatory fear of pain combined ranked only 5th on the list of reasons patients gave for requesting a lethal prescription. The most frequent reasons were not being able to participate in life's activities, 88%, loss of dignity, 64%, loss of control of body functions, 47%, becoming a burden to family and friends, 42%, and finally, pain combined with fear of pain is 34%. And Washington State virtually mirrors these statistics. These are not adequate justifications for ending one's life. These are issues that require supportive care and treatment. I am very concerned that our state cannot assure access to private and public high-quality health care for all Illinoisans, which includes hospice, palliative care, and mental health services. Then advancing this bill is irresponsible. In my experience, giving patients diagnosed with a serious illness specialized, comprehensive, holistic palliative care services will provide the relief from symptoms and stress from the illness. This is the kind of specialized and skilled medical care we need for all our patients who suffer from chronic serious illnesses. Physician-assisted suicide is not medical treatment. Physician-assisted suicide is not safe policy and has too many open areas for potential abuse. Corporations are making implicit bias training mandatory for all employees. There's a reason for this. It's because bias exists even now. A 2021 study published in Health Affairs found that 82% of physicians believe that people who live with significant disabilities have a lower quality of life than those without disabilities. People of color with disabilities face even greater disparities in care and bias in treatment decisions. Without strong safeguards, this bill puts marginalized lives in real danger. Physician-assisted suicide will be the answer to millions of people if Medicaid is cut off for individuals who are disabled, low income, and those who suffer from chronic illness. Please vote no to the SB 1950 bill and instead promote investment in comprehensive and accessible health care services, including palliative care services and hospice services. Thank you.
Thank you for your testimony. And finally, Mr. Nels, go ahead when you're ready.
Thank you. Good morning, members of the House Executive Committee. My name is Sebastian Nels, and I'm the Healthcare and Home and Community-Based Services Policy Analyst with Access Living, a historical disability service and advocacy center led by and for people with disabilities in Chicago. Access Living has monitored and engaged on the national debate regarding end-of-life options since the 1980s. Disability organizations across Illinois and the nation have maintained the stance that assisted suicide provides an additional avenue for people with disabilities to experience harmful discrimination within healthcare. I'd like to present some of Access Living's concerns on this issue. The lives of people with disabilities, low-income individuals, people of color, undocumented immigrants, and those who are incarcerated are already under threat. Proposed federal Medicaid cuts will leave hundreds of thousands of Illinoisans without access to preventative and end-of-life care. Down the hall in the rotunda, advocates, including Access Living staff and consumers, are gathering to protect those enrolled in HBIA and HBIS, as over 30,000 immigrants and seniors are at risk of losing access to essential medication and services, such as insulin and dialysis. Out of the over 35,000 individuals incarcerated within the Illinois Department of Corrections, none have access to hospice care. If our state cannot assure the private and public high-quality care for Illinoisans, which includes hospice, palliative, and mental health services, then advancing a policy that promotes this end-of-life option creates a binary of those who have the privilege to access full-spectrum end-of-life care and those who will be steered towards assisted suicide. I'd like to also take some time to address some of the misconceptions about assisted suicide. Proponents have stated that there have been 0 cases of coercion. However, out of the 10 states in the District of Washington, D.C. that have legalized assisted suicide, Washington State is the only one with an accessible system for capturing provider violations, including coercions. New Jersey, Maine, and Colorado have agencies responsible for investigating violations, but do not name any mechanisms to report coercion. If a patient does not know how to report coercion, the likelihood of coercion being reported decreases significantly. Additionally, this bill language does not establish a reporting mechanism or charge an agency with investigating such claims in the state of Illinois. Language charging IDPH with collecting and reviewing forms for compliance was removed via SB 9's Senate Amendment 1. Proponents argue that this does not impact reporting data. However, not having an agency responsible for ensuring compliance threatens the validity of reporting data because the threat of punishment for falsifying physician forms is not enough if there was no one reviewing them to ensure ethics and compliance. Illinois would become one of the few states without an agency responsible for compliance and the only state without an authority explicitly mandated to review physician forms. We understand disability is not considered a qualifier for assisted suicide. However, people with disabilities systematically receive subpar health care due to pervasive inequalities. I would like you all to return to the time that we were all trying to survive COVID-19. When shortages of ventilators were present across the nation, ventilator policies were constructed to prioritize people without disabilities because of the perceived notion and belief that disabled lives are less valuable than non-disabled lives, leading to the preventable death of thousands of people with disabilities. Arguments have been made that assisted suicide offers patients a choice. However, a system that denies people care, justice, and dignity throughout their lives cannot claim to offer choice at their death. An individual choosing between paying out of pocket for life-extending treatment or inexpensive assisted suicide because federal cuts does not have a choice. Someone incarcerated in IDOC with a terminal diagnosis, choosing between dying slowly in a cell or using assisted suicide, does not have a choice. And an immigrant who lost access to dialysis or chemotherapy and is now terminal does not have a choice in this matter. SB 9 stalled in the Senate, despite proponents claiming overwhelming support because legislators understood its impact after speaking with disability advocates and their constituents. SB 1950 is an attempt to pass a very problematic bill during the final and busiest days of session, leaving House legislators little time to engage those who will be most harmed by this legislation. This bill carries far too many loopholes and lacks oversight to be safe and equitable, but the bottom line for Access Living is this. The existence of assisted suicide is a threat to not just the kind of health care we deserve, but a threat to our ability to live and die with dignity. We urge you to vote not based on allegiance to power, but to vote your conscience. Vote no on this amendment and any assisted suicide legislation. Thank you so much.
Okay, thank you all for that. We will now go to questions from members. I think we're going to let everyone have a chance to make questions and comments. We'd ask that you keep them brief. We will do follow-ups if time permits. Do I have members seeking recognition? Okay, see Dr. Howder. Go ahead.
Thank you, Madam Chair. Well, thank you all for that. I just want to say again, to start with, deep sympathy for the stories we've heard today, heart-wrenching stories. They're really quite touching. And being a physician and taking care of patients since 1997 when I graduated from medical school, I also have a deep sense of duty to these patients. The medicine has dedicated a lot of effort and to this subject, and it is true medical aid in dying when you're talking about palliative care and hospice care. We recognize how important these patients are, and so we've made great advances in hospice care and in palliative care. Look, I wish I was eloquent, and I'm definitely not an eloquent person. I just have been taking care of patients, and now I'm a state representative. I'm definitely not speaking for the whole House of Medicine, but I do think I can confidently speak for a significant majority of the House of Medicine in that this topic really violates and is incompatible with our oath, our sacred and ancient oath, and what we've been taught. And that's why we have so much problem with it. There's two sides to this issue, and I'll get to questions, but this is such a huge, important topic, and there's people I respect on both sides of this. Mentors of mine have a difference with me. And with that, this is such a huge, important topic that Leader Gabel, I have to object to the process that we are tackling this today. And it was mentioned a little bit in testimony, but when you have a process where fundamentally changing the practice of medicine, and we're putting inside of a shell bill with little chance for really important stakeholders. I know I have many colleagues who are so confused by this process. They thought it was in rules, and now they want a chance to speak on this, and they're working. And many physicians that I know have been texting me and emailing me and said, "What in the world is going on?" And I would just like to give you a chance to respond. We have 3 days left in session, and I have real concerns about a process like this that will fundamentally change the practice of medicine. How do you respond to that?
So we had a subject matter hearing on this a couple weeks ago. Everybody was allowed to say what they needed to say. I don't think that this bill or this issue has been a secret by any means. It has been discussed thoroughly and a lot during this session, both in the House and in the Senate. I have been working on this bill for 6 years, maybe. It has not been a secret bill or secret issue. The issue of it being in a Senate bill as an amendment is that we are nearing the end of session now, and a House bill would have taken too long to get through the process. It's not unusual for bills to be added to a bill from the other chamber at this time of year. My intent was not to surprise anyone or hide it from anyone, or we all were aware that this bill was going to get called this year. So I have no desire to trick anybody or fool anybody.
Okay, thank you. And do I have your word that this will not be put into a larger bill, like a budget omnibus or a
No,
Medicaid
it will be called on its own.
on its own? So maybe I know I have limited time. I don't want to take a lot of time, and maybe I could just get quick responses. If you want to elaborate, that's fine. I'm not trying to limit you at all, but what is your response that a bill like this or a law like this will limit research that has been advancing very positively in hospice and palliative care, the specialties of hospice and palliative care.
This is just one of the options in end of life. Hospice and palliative care will still be considered important and some of the main things that people will use. As you know, there are very few people, 1% a year, that actually use this method. So I don't think it will impact them at all.
My understanding is that this is a bill that requires if the physician or pharmacist does not want to participate in prescribing or dispensing the medications, that they have to refer to someone who does. What is your response to those who would consider that complicit in physician-assisted suicide?
Yeah, with this bill, as in all medical practices, the Healthcare Right of Conscience Act applies, and in that bill, it says if you do not want to provide the service, you just need to let people know of someplace else they can go.
And if they don't want to do that, they would consider that complicit.
You know, it is. If it's the law, then they would be required to, they don't have to say absolutely go to this place. What they can say is what we've done in abortion care is they can show them the phone book and some names of gynecologists that may help them.
Is there a penalty if they refuse to even do that?
Is there a penalty? Yeah.
So the Healthcare Right of Conscience Act is
Can you identify yourself for the record?
Sorry, Kadeen Bennett with the ACLU of Illinois. The Healthcare Right of Conscience Act is something that was passed a bit ago. It was amended to include the provisions that allows for the requirement to let people know whether or not somebody provides a service and where they could go to. That's what doctors and physicians, medical providers are already covered by. They're already practicing, especially people who, for conscience objections, don't want to provide that kind of care. So nothing changes about the law. So the same process that exists right now for somebody who does not want to be involved in a particular medical procedure would happen here. And we're very explicit that as long as people follow the Healthcare Right of Conscience Act, there is no penalty or liability for not providing the care as long as it's in line with HCRA.
So just going to point out that in the large swaths of Illinois, there'll be pharmacists and physicians who will not want to participate at all. And so the availability would be in question. And I just want to make sure that those physicians and those pharmacists who do not want to participate at all, there's no penalty if they say, I don't participate in this and I don't know of anyone who does.
As long as they're following what's required under HCRA.
Last, just a set of questions. Inevitably, we talk about expansion, coercion, if you want to call it sliding, slippery slope, or the pressure, that insurance companies. I know you have said that there's no documented coercion, but I just disagree with that, and some of the testimony disagrees with that. There always is, disability groups, other groups have pointed out, there may not be coercion that you can actually point to and prosecute, but once this law becomes available, there's a subtle and inevitable pressure that people who are vulnerable or disabled have a subtle pressure that they have a duty to die. And do you acknowledge this?
No, I disagree. This is a choice that people can make. I believe that most people, just about all people, who have a desire to live, I don't believe that anybody will take this medicine unless they are suffering. And I feel like there are many requirements and guardrails on this. If people, well, that's all I'll say.
Okay, thank you for that. And the last question I have is that, again, we understand representation, and we understand we represent our constituents who they don't always agree with us, but we try to represent our constituents. What is your response to large medical groups who represent physicians, whether it be the American Medical Association, American College of Physicians, the Illinois State Medical Society have remained consistently opposed to all forms of physician-assisted suicide.
Dr. Howder, I would say that this is an issue where it's gone back and forth, even with the Illinois Medical Society. They've had a position of neutrality, they've had a position of opposition, they've had a position of neutrality, like it's gone back and forth. And I think that reflects the different perspectives that medical folks have on this issue. So I guess that would be how I would answer it. It's not that we've had situations where everybody who's a part of a membership of any of those associations, 100% of people are opposed to it. I think it's complicated. And people bring their own perspectives to the issue.
Thank you. Thank you.
Okay, thank you. Leader Hammond.
Thank you, Madam Chair. And Leader Gabel, just a real quick question. So early on in your testimony, you stated that insurance companies cannot deny coverage due to suicide. What if the contract for the insurance coverage specifically states that there is no benefit payable if suicide is the cause of death?
Well, this is not suicide. It's medical aid in dying, and it is it cannot be the cause of death on the death certificate will be listed as the disease that the person has. It will not be listed as suicide.
I'm not an attorney. I didn't stay in the Holiday Inn Express, but I think that's a whole nother animal we're getting into.
Well, we've had 28 years of experience with this law, and there has never been an incident where insurance didn't pay because they claimed it was suicide, even though the death certificate said
in
something
states
else.
other than Illinois.
And Leader Hammond,
Thank you.
This may answer your question, but it's very explicit that under medical aid in dying, if this were to become law, then insurance companies can't condition any kind of policy on the use or not using medical aid in dying. And I think to Leader Gabel's point, because this is a medical practice and not suicide, as you've heard from Deb and Susie, these are people who want to live. It is not suicide, it is medical aid in dying. That's a defined term. It's defined in all of those other states. Then it wouldn't be considered suicide for existing law when they talk about a suicide. It's a medical procedure that's legal and safe. Thanks.
Okay, Leader West.
Thank you, Madam Chair, and thank you to everyone who provided testimony on today, both the proponents and the opponents. It's very imperative that we listen to both sides of this issue. I stepped away. I think, Leader Hammond, you may have asked the question, but I had to step away to call my wife, who's an insurance agent. My concern is about insurance as well. There's a 2-year suicide clause, and there's a contestability. That the insurance agents or the insurances, they have a right, they have within that 2 years to contest. Can you speak to me if I am in that position of being terminally ill and I decide to do this and I have very good life insurance, because that's what my wife made sure I did when we got together. What happens to my life insurance if I decide to do this myself?
So if you use the law, if this bill becomes a law and the law is in effect, and you go through the process, following the process, and you're qualified, then your current insurance policy that talks about suicide, that wouldn't apply to this kind of care because it is the spectrum of end-of-life options like hospice care, palliative care. So medical aid in dying would not fall under what's defined as suicide in existing policies.
Okay, thank you. Next question, on the lines of people dying by suicide currently. Is there anyone who can speak on if there's any data around those who have been diagnosed with a terminal condition? Any current data on those who may take their life by suicide currently? Do we have any data points on that?
I do not.
And I don't know if Callie from Compassion Choices wants to answer that question. We have general information about it. What we've heard is that this is from Dignity in Dying. So some estimates suggest a large number of suicide attempts among terminally ill individuals, around 3,000 to 6,500 yearly. But this is just general information that we received. I can come back to you with more detailed information. We don't have information about Illinois. We don't have information about all other states. I would say if people are concerned about folks who are going to commit suicide because they're terminal, I would argue that this allows for a process where if somebody is terminal, they're seeking this option out, that they have to talk to 2 doctors, an attending and a consulting. At each point, if there's a perception that I'm initiating this kind of care because I am depressed, because I feel like suicide is my only option, they're required to then refer that person to a licensed mental health care professional who will offer them skills, tools. They won't be qualified for this if it's just simply because I want to kill myself, I'm depressed, without having a process and to figure out if that person has the mental capacity to make this decision.
Gotcha.
If I could quickly add to that, and I'll get personal really quickly. You know, I have had experience with depression. I have had experience with suicidal thought as well. And I know that this experience, that oftentimes I did a very good job of hiding those symptoms of depression from my friends and family. So understanding where it's not necessarily that if you have depression or you have suicidal ideation, that presents in a lack of capacity. Because we've known that this is commonplace where somebody goes, oh, and you know, I never thought that this was happening. I never knew that this was going on behind the scenes. But I will just quickly add as well, is that there have been attempts in other states, so say for instance Maryland, that had been considering assisted suicide, where they had placed an amendment to their bill to mandate that psychiatric evaluations take place for all individuals who were seeking assisted suicide. But it was Compassionate Choices, one of the proponents of the bills, that labeled this as excessive, which later led to a slew of Democratic senators there that had said, well, this is not excessive. If anything, that we are ensuring that there are truly safeguards, right? Because it is hard to determine whether or not somebody has depression or whether somebody has suicidal ideation as well. But none of those are present in this bill currently.
Is it possible, just to that point that you made, I would say, one, because you're terminal, it doesn't mean they're not capable of making decisions about your healthcare. People who are terminal make decisions to decide to stop undergoing treatment. There's no requirement before you do that you have to see a licensed mental health care professional. So this is meeting people where they are and tailoring a law so that folks who don't need to go to a licensed mental health care professional aren't obligated to, and they may be seeking that kind of care on their own. I think in terms of, you know, I just think about Deb, who has said that she wants to live. Like, she is a person who, if she's done all of the trials that she could, she is now at the end of her time, and she wants this option available in case she needs it. So we won't then say, well, Deb, because you're contemplating this choice, you should go to a mental health professional. It's about the doctor in their own medical judgment assessing whether or not this person needs that kind of care.
Thank you. Last question. Go ahead.
Can I just say something just ever so briefly?
Sure.
I am a mental health professional. My whole life I spent with young people trying to help them not make the decision to commit suicide. So I kind of it's very emotional for me when we talk about physician-assisted suicide in regard to medical aid in dying, because of the fact that, you know, as I've said, I don't want to die. I don't have a choice. And, you know, spending 30 years trying to help people live their lives and love their lives made me the person who I am today. And that's why I cherish life and I want to stay alive. And that's why I'm doing everything I possibly can to have that happen. Thanks.
Thank you for that. I appreciate that. Last question from me, at least, because I need to get all you're getting understanding. I lost all activities of my limbs. I am bound to a chair. I can't feed myself. I receive a terminal diagnosis, and I orally say, I want to do this. but I'm in a position where I can't feed myself. Where does that leave me?
You would not qualify.
Okay, thank you.
Okay, does anyone else? Leader Spain?
Thank you, Madam Chair. Leader Gabel, maybe let's start with a question I have for you. Is the Amendment 2 that we're reviewing and considering now, is it the same language in which we had the subject matter hearing on this topic a week and a half ago?
Yes, it is. No? Oh.
So if it's not, if you could just go through what are those differences, please.
Sorry. Some of the language that we have reflects changes that were asked for by members of the Hospital and folks from the governor's office. And so the first part of it is language that would essentially create findings under the law. So that's the first section. There's language that would, in the sections dealing with healthcare protections, be explicit that all of the protections and liabilities that are afforded to individuals are also afforded to healthcare entities. There's language that makes it explicit that if a healthcare provider wants to participate, so let's say they have a patient who is qualified for the process, they're able to get the prescription. They work for a healthcare entity that does not allow for medical aid in dying. If they want to, on their own time, go be with the patient at the end of their lives, then they have to be very clear that they are not affiliated with that healthcare entity. And if they don't do that, then they would be subject to disciplinary action that is similar to existing disciplinary action. There is language that requires the Department of Insurance allows them to do enforcement of the provision that deals with insurance. There's language that requires the Department of Public Health to do rulemaking around certain items, including reporting items as well. The Department of Insurance and Public Health asked us to pull out language that would require them to follow up with doctors who don't file the forms, because that is not within their wheelhouse of the ability to do that. There is language that would move the effective date from 6 months to 9 months. There is language that also allows for, at the request of the Department of Veterans Affairs, to do rulemaking because they would not allow for medical aid in dying in their facilities because it would violate federal law issues there. There were some duplicative language that we removed, but those are some of the high points.
Thank you. Thank you for that. I appreciate understanding those changes. So let me go to HICRA, Ms. Bennett, while you're still up here, because I think you have strong expertise here. And I just, along the same lines of Dr. Howder, wanted to make sure I understand this explicitly. So the bill contains incorporations by reference to HICRA. So now I'm over on HICRA within section 6.1. And I don't know that it's necessary for you to have this up, but just so I want to walk through this. If requested by a patient or legal representative of the patient, the healthcare facility, physician, or healthcare personnel shall refer a patient to another provider who they reasonably believe may offer the healthcare service. Can you just speak more about that requirement? And I know we often make a reference to the guidance that occurs within the issue of abortion. This may end up playing out a little bit differently based on the data we've seen for other states about the real limited number of physicians that are interested in being part of this new type of practice. So how is this going to work, as Dr. Howder talked about, for a physician that does not want to be a part of this action?
So it would be the same way that it would work for any other kind of healthcare that a physician does not want to do. So if I'm coming to you, Dr. Howder, and I said that I've learned about that I'm terminal, I've learned about all of my options, including palliative care, hospice care. I've sat with my family, and I've decided that I want to initiate this care. I would go to you and say, is this something that you do? I heard that this is an option. I've thought about it. Here's why I want to do it. Let's say you don't think you think I have the mental capacity that I don't need to seek any kind of further mental health care. You would say, I don't provide this care. Under HCRA, I am required to do these things. I don't know who provides this care in town. You may want to search a website, or you may want to contact IDPHR. They may know of where you can go. So that is an example of what you can do to qualify. I guess I want to stress the reason why we have a reference to the Healthcare Right of Conscience Act throughout this law is because we respect people's ability and desire to not provide care they don't want to provide. And I do agree with you, because by doing that, we could have required everyone to do it, and that would allow for more access to this care. But we want to respect the Healthcare Right of Conscience Act, which Leader Gabel passed that law. But we want it to be clear that you don't have to learn a new process. It's the existing process that you have to continue with.
Okay, and just as an additional clarification, Section 4 within HCRA regarding liability, no physician or healthcare personnel shall be civilly or criminally liable for their refusal to perform, assist, counsel, suggest, recommend, or refer in any way to a form of healthcare service that is contrary to the conscience of that physician or healthcare personnel. So that liability remains and is included through an incorporated reference to HCRA in this bill, correct?
And just to be clear, if you are following what's required under HCRA, then your liability won't be there. And we're very clear in the law that if you're following the requirements under the law and as it relates to HCRA, then liability won't attach.
Okay, thank you. Going back to the bill, one of the question that I just don't know the answer to, I'm sure it's in here somewhere. What is the age of consent for a patient to be able to initiate this process?
You're only an adult patient. So in order to qualify, you have to be an adult. An adult is defined as 18 or over. And
18 years old. Okay. And I was looking through during prep for this hearing, there is a written request must be made by a patient, correct?
That's correct.
And the bill indicates the exact text that must be utilized, correct?
Yep, that's correct.
So one of the things that really jumped out at me in this written attestation, the patient, I affirmed that my terminal disease diagnosis was given or confirmed during at least one in-person visit, to a healthcare professional. We define healthcare professional as how do we define what is a healthcare professional?
Healthcare professional, so it's page 5, line 14, means a physician, pharmacist, or licensed mental health professional.
So a patient can, through this written statement, what is a licensed mental health professional?
That is, what is a licensed mental health professional? So that would be somebody who would be a clinical, let me find the exact language, social worker, an advanced practice registered nurse who has that knowledge. Sorry, I'm just finding that language. Yeah, so it is means a psychiatrist, clinical psychologist, clinical social worker, or advanced practice registered nurse.
So we've called this medical aid in dying, we've called this physician suicide, but it's much broader than that. You could be an LCSW offering an in-person visit, and you qualify under the written attestation of this patient of having the in-person visit.
Well, part before, I, name of patient, am an adult of sound mind and a resident of Illinois. I've been diagnosed with the condition and given a terminal disease prognosis of 6 months or less to live by my attending physician. So that is a core place that needs to happen. And then the given or confirm, you could have been given that in person with your doctor or your attending, or the doctor who originally said that you were terminal, and the confirmation could happen by a licensed healthcare professional.
So we've talked about, I believe Dr. Howder during our subject matter admitted that sometimes physicians aren't always great about giving a particular diagnosis, a terminal diagnosis, a prognosis of 6 months left to live. This would seem really to be doubling down on that uncertainty. So you could have a physician that has given that diagnosis, and then it could be confirmed by a list of different healthcare professionals that may be very far removed from being a physician. Is that correct?
The law requires confirmation from a consulting physician.
So
it would be two
physicians, or one physician plus a mental health worker or a pharmacist,
a
or
healthcare professional with consulting, with approval from a consulting physician.
In order to meet the requirements of the law to be qualified, there has to be an attending physician and a consulting physician. The point of the consulting physician is to confirm that that person is terminal. The language as written is to, so they've already had two consulting people who have said, so the attending, the consulting at least, who have said that they're terminal. This would allow, let's say they have to get a licensed mental health evaluation, an evaluation from a licensed mental health provider. That can also qualify because they've seen those two doctors. Those two doctors have said, Kadeen is terminal. We need you to do a mental health consult. That person then knows that I am diagnosed with a terminal illness. So that would capture that.
are there provisions within the bill that protect against doctor shopping? So in other words, I approach a first doctor and says, boy, I'm not sure about you doing this. I'm going to require a mental health consult before you can proceed. Would I be able to go and find a different doctor who may feel differently?
So one, I think a doctor who decides, I'm just going to let you do it because you want to, would probably lose their license. I would imagine that this is, as we're having this conversation right now, a very sensitive issue, and all eyes would be on that doctor. We've not heard of that happening in other states. I know that in some states, because and I could imagine because of what you both have shared, there are only so many doctors who are willing to provide this care. It could be a situation where, 2 years from now, we see in this part of the state, there's only 2 doctors who are doing it. That wouldn't be doctor shopping. That would be the only people who are available. And if a doctor knows that that person isn't qualified and then allows them to have access to this treatment, they could also lose their license.
No, I understand that, and there may not be a large amount of participation. But again, just it occurs to me that we don't have a universal medical record that follows all of us everywhere we go. So there may be a recommendation by one physician in accordance with this written attestation that may not be understood by other physicians who are involved at a later time. So that's just an observation to me. I think, the reason I think that this written statement is so important, and I really do think that there's some significant flaws in it that could be rewritten differently if this goes forward. But, this is the language that most of the patients are going to look at. They may not go through pages of legislative texts and, go back to the archives of the General Assembly and study this debate, but they will see this exact prescribed written statement, request for medication to end my life in a peaceful manner. And I think there are some contradictions within it. Let me bring my comments to a close with just one more thing. Leader Gabel, you know that I filed a fiscal note on this bill, and then I noticed that you filed a slew of additional notes. So I wanted to understand your intention with regard to those notes.
Well, as you know, Sometimes a tactic of opponents is to just file individual notes on every day to postpone the ability to hear the bill, and I just didn't want that to occur.
And that's within your right as the sponsor for those additional notes, but what is your intention with regard to the fiscal note? I didn't file a dozen notes. I filed one specific note because I'm interested in the fiscal impact on
Yeah, I'm going to ask for it to be done.
Okay, thank you.
Okay, I don't see anyone else. Go ahead.
Thank you. I have a few brief questions. First, should this make it out of committee today and to the floor to be debated, can I request that that the original bill dealt with food handling? And so that will be the title that we see up on the screen. Can you make sure to let people know that this has nothing to do with food handling? I would say that they're two completely different topics, so I wish we would have picked a different vehicle.
Yeah, I didn't have a lot of options with the vehicle, so I'm sorry about that. But yes, I will make it well known.
And I understand that this often does happen. I don't think it's good practice, especially on a bill as important as this. This certainly had time to go through the process, the normal process. But so what type of relationship is an individual required to have with their physician in order to pursue assisted suicide?
If I can answer, I could ask Dr. Barnard to answer it since she is a provider. Do you have a preference?
It doesn't matter. I'm just looking for an answer. I don't know if, do you have to have an established relationship with the person that's providing this drug?
Dr. Barnard, do you want to answer?
Sure. The bill, like other bills, requires that the individual make a request for medical aid in dying to a physician who is required to do several things. Make an independent evaluation of the patient situation by reviewing the records and doing an exam. Take the voluntary request once. That patient then needs to see that physician a second time to reiterate their request after a waiting period. And unlike many other things that are done in medicine, there is a mandatory consulting physician visit who makes their own independent evaluation by reviewing the records and talking to the patient and determining if they qualify. And then that written request that was referred to is the fourth ask. So these requirements are safeguards to assure that the patient is carefully evaluated to be sure that they qualify.
And Representative Levy, to answer your question.
If I may also just follow up immediately on that, I just want to point out that
I'm sorry, what was the question again that we're answering? You were asked about the relationship?
Yes, what relationship with the physician is required?
The other witness can briefly answer, and then, but please keep it to the question, and then Ms. Bennett.
Yeah, absolutely. Thank you. I just want to point out that Oregon Health Authority's public reports on the 2,454 assisted suicide deaths from 1998 to 2022 has shown that there's been a reduction in the length of the physician-patient relationship from 18 weeks in 2010 to just 5 weeks in 2022. So we are getting faster and faster with this process.
And to address your question, so I would use Deb as an example because we've talked about this law and what happens if it were to be implemented. She has a team of doctors that she's seeing consistently to address her terminal illness. Her doctors may not be doctors who also want to participate in medical aid in dying, so it may be to establish a new relationship in order to have access to this care. The bill is silent on it because our healthcare system is what it is. Like, I had to change my insurance plan overnight. So, and I'm developing a new relationship, so we didn't want to put a timeline, but we do have those steps that have to be in place so that they have a holistic idea of that person's medical history.
The only reason I ask, and I think we all know, I would think that we all know somebody who has had a very tough end of life. My dad's best friend went through it a few years ago, and it was hard to see. But I want to make sure that, 2 visits with the physician and a second consulting visit. It sounds like I had more than that when I had my Achilles tendon surgery, right? So I want to make sure when people are making a permanent decision, this is permanent, that relationship is established. And so it's tough for me to understand how somebody who may be in the business, right, they get paid to be part of end of life prescriptions, right? How that person isn't incentivized to push people in this direction. And I'm not saying that doctors want to go this direction, but when you're paid specifically to provide that service, I have a concern that that is a business that you are in and you are going to lead people in that direction. So what Leader West asked earlier in regards to an individual who may be quadriplegic, can't feed themselves, if they were to choose to go this, they're of sound mind, if they were to choose to go this direction, are we not allowing them to have the same rights as everyone else because they are disabled?
The requirements are that you have to be able to take the medicine yourself, either orally, rectally, or.
So are we discriminating
against?
Are we discriminating against individuals who may choose that
It is
path?
it's a protection to make sure, because they can't. I just want to make sure that nobody else coerces them. It doesn't for them.
So I certainly understand that point, but are we also setting ourselves up for discrimination against individuals who don't have that ability?
We don't think it's discrimination. I think it's that balance we have to strike, where I've come to you on bills where, reproductive rights, in terms of, there are lots of hurdles that we don't want to have in place. Here is an issue because of the sensitive nature. We have lots of safeguards in place. I think if we didn't have that safeguard, we would be dinged for not having that safeguard. We want to make sure that people are able to know what they're doing at the time that they have the prescription. They are in control, and this is all about having terminal patients have control. They're able to be in control of taking the medication. We've heard from people who are who may be living with dementia, who feel that we're not going far enough, but our ultimate goal is to make sure that at the moment you're taking the medication, you are able to do it, and it's not Uncle Frank. No offense to people,
and I understand why you're doing it.
Yeah.
I'm just wondering if it's setting it up. So the document, the language that's included in the bill for the document to declare that you want to pursue assisted suicide, does that document have to be notarized, or how do we know that the individual who it's for is the actual one who signed it?
So there is a requirement to have witnesses sign the document, so affirming that the person who has signed it is actually the person who they say they are. One witness is somebody who has to be neutral, so they have nothing to gain from that person's death. They have no relationship with that person. And then another witness in place. We have those two people. It's not two people who have no relationship with them, because there are some people who don't have two people in their lives who would fall under that category.
And I would think that there's a reason why we have notaries. So I think that would be an important, they have to take training, they have to know why and what they're looking for with an individual when they're attesting to that individual signing it. So I would think that you'd want to do that.
Oh, so sorry. Maybe this will answer your question as well. This document goes to their doctor, so their doctor gets it. And if it's Robyn Gabel and it's me, they would also know that it's not the right person.
Yeah. No, and I understand that. I'll leave it at that for now, but I think there's a number of issues that we still need to discuss, and this is a very tough issue. I don't think anybody wants anybody to go through the end of their life suffering, but as I've watched individuals go through that, we all see them have some very bad days and some very good days, and we want to make sure that they're not caught on those bad days. So. Thank you.
Okay, Leader Tarver. Sorry. Okay, one moment. Okay, I will note that I do have a subletter in place replacing permanent member Representative Gordon Booth with temporary member Representative Gabel. And before we go to a vote, I wanted to just make a comment. I've given a lot of thought to this topic and listened, of course, to the witnesses today, but have met with many people in my office over the past several years that Leader Gabel's been working on this bill. I can't help but think about it in the context of my own family. My father passed away in December of 2020 after a long, very difficult illness. And throughout this conversation, I think what I came to realize is what may be right for one person's family may not be right for another individual or family. So at the end of the day, for me as a policy decision, I think we should allow people the right to bodily autonomy in these situations and the right to self-determination. So I will be supporting the bill. But I wanted to make my own comment and thank everyone for their input, for the decorum that we've generally maintained over the past 2 hearings, which have been very powerful and emotional. So thank you all for that. With that, we'll hold one moment and then proceed to the roll call. Okay, seeing no further debate, Leader Rita moves to recommend that House Floor Amendment number 2 to Senate Bill 1950 be adopted. Clerk, please call the roll.
Williams.
Yes.
Rita. Spain.
No.
Davidsmeyer. Hammond. Hernandez. Ma. Smith. Tarver.
Hey, just briefly, thank you, Madam Chair, for the opportunity to make a couple of quick comments, and thank you for bringing this bill forward. I've talked to the sponsor and to the advocates. This is an incredibly difficult issue for me in my district. I do want to be supportive of Majority Leader Gabel to get this to the floor. So I will be a yes now. I cannot commit to being a yes on the floor. Thank you, Madam Chair.
West. Howder.
No.
Gable.
Okay, there being 8 votes in favor, 4 votes opposed, and 0 voting present, House Floor Amendment number 2 to Senate Bill 1950 is recommended for adoption and will be favorably reported to the House floor. The Executive Committee will stand in recess until the call of the chair. Thank you.